Okay, I guess we can start now. Good afternoon, everyone, and welcome to a very special webinar here with us today. I am Dr. Khalid Al-Dosari, a health policy manager at the Center for Value in Health, and I would like to welcome you into today's webinar and to as I say, delivering the how the value-based care will support the Saudi model of care, and would like to welcome everyone for the session today, or I would say as the Saudi healthcare transformation is going on, and with the model of care implementation, it's really important to account for the measurement of the outcomes for the services that are being delivered, and our practitioners and frontliners must be prepared to measure and report and also leverage both clinical and patient-reported outcomes. So in collaboration with the Center of Value in Health with Capadev Saudi Arabia, today's session will explore how the value-based health and care principles and outcomes measurement underpin the successful rollout of the Saudi model of care. And it's really my pleasure to introduce our distinguished speakers. First of all, we have Dr. Reem Al-Bunyan, the Chief Executive Officer for the Center for Value in Health, and also the Executive Director of the G20 Global Innovation Hub for Improving Value in Health. She is a consultant neurologist by practice, specializing in multiple sclerosis. And Dr. Reem will set the context for today's session about value-based healthcare in Saudi Arabia. We're also pleased to have with us Dr. Sally Lewis. Dr. Sally Lewis is a professor of Value and Health Management, Swansea University, and also the founding director of the Welsh Value and Health Center, and also the affiliate partner of Capadev with over 24 years as a GP. Dr. Sally will discuss the outcomes and the outcomes measurement. We're also pleased to have with us today Mr. Faris Saadi. Mr. Faris is a partner at the Capadev Saudi Arabia. He's a healthcare transformation strategist, leading value-based healthcare transitions and capability building across Europe and the GCC. He will share on-ground lessons and learnings from the outcomes rollout and implementations, inshallah. So I would like to remind you, our esteemed guests, to use the Q&A function here in the webinar, as we will have a time to accommodate your questions as many as possible. So Dr. Reem, without further ado, please, mic over to you.
Thank you very much. Assalamu alaikum, and I am thoroughly delighted to be with you today for this special webinar that we put together for you with much thought and passion and excitement. Khalid mentioned that I lead Value in Health, which is a national think tank. Sometimes we say we're a think-do tank because we focus on a topic and we exist for a reason to be a catalyst for improving value in health and care in our ecosystem. And I want to say a couple of words before going to what we mean by value. We know that this is a movement in health systems around the world to focus on outcomes, not just any outcomes, but outcomes that matter the most in relation to what resources we use to realize them, whether it's my time, whether it's me as a frontline clinician or my colleague, or the interdisciplinary approach, or any other and all other resources, drugs, beds, anything. And we say that this is something that everyone that's involved in the health sector needs to understand, and also needs to understand their role towards realizing this. The challenge is in speaking about implementation, and today's talk is all about implementation. We know that there is no one way to implement and realize a high value, particularly since we in the Kingdom of Saudi Arabia are on a whole of sector transformation. So, two things to say before handing over to Sally. One is that we need to converge around what we mean by value. And we always say that the diagram or our framework for what value means is a diamond, because it signifies a gem, and that health is a gem, a very precious gem. And half of it is outcomes that matter the most, and the other half is the resources we use to realize them. And in our setting, we are a nation that is committed to universal health coverage politically and holistically and socially and in every way. So we have three dimensions as we look at this: the person in the middle, the immediate community and family in the center, and then the largest ring you see is the population at large. This is why it is our view that the clinical transformation is a continuum. The newly named Saudi models of care exist to realize this. And it's a continuum from the models of care to service line work to population health management. It's all one thing that is interconnected. And everyone has a role in realizing this. In today's conversation, we will hear from Sally, who we actually had the pleasure of visiting and meeting her and the team and the outstanding work that was done. She will share with us her experience in actually doing this. And then Faris will share some experience that we've had in our nation and a perspective on how we can scale and accelerate this movement. And then we'll come back with some questions and commentary at the end. With that, I would like to invite you, Sally, to go next, and we're really delighted to have you.
Thank you. Thank you very much, Dr. Reem. And I had the pleasure of meeting Dr. Reem and her team for the first time. I think it was in February last year when they came over to Wales. And the striking thing for me about that visit actually was how identical our approach was to value in health and population health in the context of universal healthcare. And we'd arrived at the same views on what this looked like independently, actually. So huge amounts of synergy between Wales and Saudi Arabia, and indeed other countries who have put value-based healthcare and population health very much together. So hopefully the slides will be coming up in a moment.
Are you able to see them?
Yes, I can see them now. If you could
Okay.
advance, that would be great. Thank you. Okay, So, what I want to put across from a practical implementation point of view today is that value-based healthcare does not and should not be an extra to the model of care. It should be seen as a tool with which to deliver the model of care. And I was really interested to dig into what the model of care means for Saudi Arabia in recent weeks. So what we're going to cover today is value-based approaches to delivering the model of care. It's very similar to my experiences of delivering integrated care models in Wales over the last 10 years or so, and to put across the fact that this is really about changing the way that we use data to create knowledge and insights and then action towards learning health and care systems. Next, please. So it's easy to get lost in value-based healthcare, I think, because it's such a vast topic and there are so many ways to add value for patients and for the population. So I like to start with a basic framework that says that there are interventions we can make at a population level, at the level of a pathway, and also, of course, for individual patients that we're treating as practitioners. And when we talk about pathways, we're really talking about end-to-end pathways wherever possible. So integrated whole pathways of care, which may start in the case of a chronic disease from prevention and go through to all the way to end-of-life care, or it may be shorter pathways like episodes of care such as a cataract surgery, for example. Next, please. So this is my summary, forgive me, of the model of care. But my understanding of the model of care is that there needs to be very much a focus on holistic and integrated care that is created when we merge together a focus on mental health in the community, social health in the community, and building community, as well as physical health. And there is, of course, this focus around chronic care, planned care episodes, so cataract surgery, hip arthroplasty and that kind of thing, and safe birth and early years. And I recognise these priorities as being very important because chronic care and planned care episodes probably create the biggest share really of volume. So we need to understand how we best meet the evolving needs of our population, whether that's in the rising prevalence of diabetes in chronic care, or whether it's coping with the increased volume that will need surgeries. And of course, safe birth and early years is probably the most important population intervention we can take from a prevention perspective to ensure good outcomes for the long term for the population. And of course, you have centered the model of care around essentially the quadruple aim, so better experience, better value, and very importantly, I think, in this era of physician burnout, increased job satisfaction for healthcare professionals and really getting back our joy of delivering care to our patients. This is really important, isn't it? But my observation from around the world is that many healthcare systems state strategic aims that they wish to pursue the quadruple aim, but then they don't actually know if they are making progress because they don't measure outcomes and they don't measure value. So we have to expand our data set and really move towards a data-driven decision making to support the strategy and the models of care that we are developing and to know that we're going in the right direction. Next, please. So part of that is, of course, to measure outcomes. And what do we mean by outcomes? Well, we mean patient-reported outcomes, of course. So outcomes that matter to people, that are really talking about quality of life. So it might be global quality of life, or it might be related to a specific condition, in which case we're talking about the burden of symptoms that is specific to that condition. Or it might be other things, psychosocial symptoms, including loneliness, and of course also the burden of care, which is complications, but also healthcare utilisation, because as people live with multiple comorbidities, very often their healthcare becomes almost a full-time job for them. So understanding how we design processes of care that don't burden patients is part of value. But alongside patient-reported outcomes, we need clinical outcomes, and we need to understand the case mix variables, so individual characteristics of those patients, and the treatment variables as well. And that obviously enables us to create in-depth analyses when we aggregate the data. And supporting clinical audit then is critical, and understanding how we gather this data in a way that is not burdensome to healthcare professionals. So hopefully extracting where possible from the electronic health record. But really the point of this slide is to highlight the cultural shift, because although we have in our healthcare systems these aspirations around the quadruple aim, and all healthcare strategies around the world talk about better outcomes, but then we measure the things which are not outcomes at all. They're time-based metrics and activity. So how many things have we done, or how long did it take for somebody to access that treatment? And for sure, these things are important, but until we add the outcomes, they're insufficient. And in my experience, this has really created a changing mindset, certainly in Wales, that has brought managers and accountants and clinicians together to understand each other's worlds and to create a common goal around better outcomes and value. Next slide, please. So digging into the pathway a little bit from the pyramid earlier on, we can divide the pathway up into a generic pathway that looks like this. And I think this could be quite helpful, an approach to support the model of care. So really starting at prevention through to early diagnosis, optimizing the intervention, and then on into follow-up care. And follow-up care is a huge opportunity, especially in chronic disease, to really redesign the system using enablers like digital enablers. Dr. Reem mentioned earlier how we might use clinical time differently, and how we really start to change the interaction between us and our patients, and challenging ourselves, I guess, by really taking a detailed analysis at each step of the pathway from the patient's perspective, not the service perspective, so we can really challenge ourselves around new ways of doing things, because we make our pathways artificially linear, don't we? But for many patients, of course, with chronic disease especially, these are not linear pathways. They are going round and round and round. It's much more complex than that. So really focusing in on that critical analysis, and the data helps us to do that. Next slide, please. So how do we challenge ourselves on the status quo? Excuse me one moment, I have COVID, so I have to make it to the end. We need to decrease unwarranted variation and low value care. We really do. And that's care that's either resulting in over-treatment or under-treatment, actually, both of which have the potential to cause harm. But we don't really know if something is unwarranted variation until we understand the outcomes. Adopting high-value innovation in a coherent way is very important. Certainly has been a challenge for us in Wales. I'd give the example of the amazing new technologies to support people with insulin-dependent diabetes, and how do we make sense of that from a technology point of view, and do that in a way that patients understand and can get the best possible outcomes. And that's very much linked to digital health and those new models of care that release capacity in the system that I hinted at earlier. The other thing about outcome measurement is that it actually is also a needs assessment. So from a subpopulation perspective, the outcomes will tell you about symptom burden and quantify it in the community, and that helps you to reduce inequalities in health. And of course, focusing on prevention, and especially secondary prevention. So really getting to grips with secondary prevention in patients who've already been diagnosed is a quick win here, I think, for the model of care. Next, please. This is an important slide. Clinicians in the room will recognise this. The constituent of a good outcome is much more than excellent processes of care, important though that is. Patients play a huge part in the outcome that they attain, and we have to figure out as a system how best to support them in their work towards the outcome. And basically that is around raising health literacy through appropriately shared information. Allowing people to access their health data is also very, very helpful. In Wales, we found that enabling patients to track their own PROM, for example, had quite a profound impact on the way they viewed their condition and engaged with their healthcare professional. And of course, on the healthcare side, that means adequate time with patients and timely access to evidence-based interventions. But this requires thought and investment. So I feel it's important in the value context to put this here. Next, please. So, using clinical and patient-reported outcomes, I like to think of this as being an outcome that's a milestone, an endpoint, or a consequence which matters to somebody. It's not just a result. So in a lot of value-based healthcare literature, you'll hear the word result. And that sort of means a finality in my mind. And actually, outcomes are far more than that. The nuances of how we use them will be slightly different in the planned care episodes compared to chronic disease, but we can track patients longitudinally, and that's such an opportunity. It's not just a result. That can support shared decision-making, helping people to make choices about the care that they wish to pursue to get the outcome that they want, and really be triggers for key conversations and raising health literacy. It also helps us with identifying variation, identifying unmet need, and I think there's also a real prize at the end of this. When we have very large data sets, we will have created large bodies of real-world information so that we're not just reliant on clinical trials carried out on an ideal population. We will be able to tell our patients, somebody like you from your background with everything that's going on in your life is likely to have this outcome if you make this choice or have this treatment. So really adding real world information to support our decision making is an extremely powerful thing. Next, please. So I wanted to show you this illustration because implementing a PROM in chronic disease comes along with a timeline with set time points, and that's to allow comparisons and analyses, very specific analyses later on. But you can add PROMs at other time points as well. The timeline that you see there is from ICHOM. It's the suggested timeline from the International Consortium for Healthcare Outcomes Measurement, of which Capadev, of course, is a partner, an implementation partner. But in the graph in the top left there, what you see is the tracking of somebody's physical function in an example of a chronic disease like heart failure over time. And we see that their physical function varies over that time depending on the stage of their diagnosis. Now, this is something we see as clinicians. So for number one, that's at diagnosis or just before diagnosis when they are really symptomatic and before we have started treatment. And our aim is for people to respond to treatment very quickly so that the graph is very steep and people stay on a plateau of function for as long as possible. But of course, as chronic diseases progress, we know that that period of clinical instability and deterioration starts to creep in. And this is where PROMs are so helpful, because it identifies, even sometimes before we're fully aware, where people are entering into these periods of instability. And it also helps us understand whether we're responding quickly enough with the treatment. So in this sense, PROMs are really a tool to support care, you know, just like a blood test or a scan. Next slide, please. So here's another example I wanted to talk to you about. In our experience in Wales, we found when we were looking at pathway redesign in our model of care, and we were trying to improve things, people got a little bit overwhelmed because there were so many things that could be done across a pathway. So using the clinical networks and our national clinical leads for different specialties, we started to create focus by asking the clinical leads, what would the most important things be to improve the outcomes in the shortest possible time? So this is the example from diabetes, actually. So loads of other important things in diabetes, but this was where our focus was early on. And you'll see that there was quite a lot going on in prevention and a remission program for type 2 diabetes. There was an awful lot going on around supporting patients in their self-management and in the implementation of technology to optimize intervention, and some things going on as well in follow-up that were really about doing the basics well and making sure that people were monitored on a regular basis. So if I relate this back to the model of care, I hope you can see that there are things in there that relate to population, pathway, and individual, but hopefully not overwhelming when there's such a lot to do all at once. Next slide, please. And this is to make the point that data transparency and visualization is very important. You will have a lot of data, and you can't consume all of it all the time. So we have to figure out ways to generate insights that people can consume at a glance. And this is just an example from Italy, from a team I've worked with for a number of years who are very, very good at producing lovely visualizations that show variation against different indicators and outcomes. Next slide, please. I'm happy to share actually more work on that if you're interested, because they're a very interesting team. And to conclude, I just wanted to share some of the ways in which we'd used PROMs specifically nationally in Wales, although it's very important, and I must emphasize value-based healthcare is not just about PROMs, but we tend to focus on it because it is a new data set. We have used PROMs, as has Saudi Arabia, very successfully in the OECD Paris survey, which is a tremendous needs assessment. We used it in the evaluation of our long COVID service, so we were able to prove that our long COVID service was effective and to enable it to continue. And we've used it a lot in supporting pathway reconfiguration in atrial fibrillation and in heart failure, particularly around speedy optimization of patients' condition and proving that using the PROMs. And we were able to triangulate in that case actually with a reduction in acute healthcare utilization, so really dramatic falls in the 30-day readmission rate for heart failure, for example. So that data triangulation is really, really important. Thank you very much for bearing with my voice. I shall now hand over to Faris. Thank you, Faris.
Thank you. Thank you so much, Sally. I hope you also get well soon. And I think you have very well covered and made the case for how we need to use outcomes, use them properly in order to enable population and pathways and people and more general model of care implement realization or bringing it to life. What I will actually cover is a bit more how we essentially in a practical sense enable the existence of outcomes that we can trust and we can use in from attending to individual patient needs to actually population level transformations and transition that we are looking to have in the Kingdom of Saudi Arabia. So essentially, what I try to cover is how does an effective outcomes rollout and use of outcomes essentially, what does it look like that really drives value-based healthcare? We will touch on the also importance of trust, and Sally also alluded to the importance of clinical audits, because data has to be trusted by within a provider, by clinicians, and it also across stakeholders. And of course, this builds on our experience globally, but also in Saudi Arabia. That's why we should actually touch upon some of the work we have done in the kingdom, which is really based on almost 25 different, we've worked on, I think, maybe 23 different providers, public providers and private providers, and also one public payer and now 2 private payers. So a little bit seeing things from different perspectives, if you like. Some initiatives were joint payer providers, so obviously also interesting to look at. So if you want to create some, think of some key headers for how do we think about assuring a proper implementation of value-based healthcare, and in particular, starting with a very solid foundation in the measurement of outcomes. I think we can group them under 3 main themes. Number 1, we need, to standardize what we are measuring. If we don't standardize, we are really not able to compare, and we're not able to learn. And this standardization is in the selection of measurements, but of course, so it goes down further into data sharing standards and definitions, and it allows also interoperability as well, and be enabled by interoperability. The second element that is equally important, if we have standardized data, we're measuring the same thing across so many different providers, but is the data right? Is it valid? Is it complete? So we also need to build trust. We need to make sure the data is trusted by everyone and is reliable to everyone, and cannot be contested by anyone. So trust is also another key success factor, another key building block in that, outcomes foundation of value-based healthcare. Now, standardization and trust, obviously we will not go very far if we don't actually have the data, if we don't have engaged both providers, and I would say providers in the clinician sense of the word, and as well as providers in the institution sense of the word, as well as engaged patients. So it's very important that the mindset, the behavior, the engagement of these 2 constituencies in that change, it's really make or break. And so it is a key element that needs to be addressed if we are to have even a pilot, but even beyond the pilot, sustainable outcomes utilization. So let's start with standardization. A good starting point for standardization is actually an ICHOM standard set. Obviously, ICHOM has done this, homework of working with, usually 30 to 40 experts, clinicians, outcomes researchers, patients all around the world. Oftentimes, by the way, many ICHOM sets have actually been developed with the involvement of Saudi leading physicians. So basically, they actually make sure they have a team globally to develop this, and it takes about 12 months. And so essentially, we have a set that has the case mix variables, the clinical outcomes, the patient-reported outcomes, and obviously this set is fairly comprehensive to some extent. So we typically start working with a selected number of these metrics, so 50, 60, 70% of them. So even ICHOM does not require that we start with these full set. And of course, there are situations where we need metrics and measures that are not found in the ICHOM set for whatever reason or purpose, these can also be added. I think what's important is that there's a core essential number of CROMs and PROMs in every disease, in every pathology that we need to make sure we all measure. So these are like the core essentials. And then we can add more depending on what our unmet needs, what our priorities are as a provider site or as a cluster or as a health system. But we have a great starting point, and we can make sure we're all standardized. And of course, with standardizations come localization. Happy to answer questions about that at the end if you wish, but obviously we're covering some select themes for today. Now, so that's standardization. In terms of building trust, also we have, ICHOM provides a way to do that. We have been doing audits ourselves and for some time, and we thought, like, why wouldn't that be incorporated into a maturity level, 3-level maturity of an ICHOM accreditation. So the current ICHOM accreditation really provides guidance to providers, and of course it recognizes providers as they reach milestones essentially in their progress implementing value-based healthcare. And by the evaluations that are embedded in an ICHOM accreditation is one simple and let's say easy way to ensure we build trust in the system, especially trust between providers on the one hand and payers and regulators on the other hand. And of course, there's also a Newsweek partnership. In an ICHOM accreditation will help boost a Newsweek, the Newsweek rating, because Newsweek pays even more attention these days to patient-reported outcomes that they've actually basically increased their weight. But essentially the ICHOM accreditation is about 3 levels that is really based. If we were to divide a little bit the transition in terms of the use of outcomes and making the most out of them for a given provider, the first level is where let's say one site has implemented coronary artery disease for one full cycle, obviously having done it in the right way with some sound collection protocol, and is starting to see aggregated results that they can use. Right. So, and when we say a cycle, we mean obviously the fact that basically they go through all the measurements along the pathway, or at least the minimal measurements that are required for level 1. And of course, with some minimal response rate or number of patients. And of course, we can go through that detail a bit if you have questions or separately. Level 2 is where the cycle has been implemented for a second time for more patients, so it's become more embedded in the organization. And of course, in level 2, there's a more detailed audit of the actual data that was collected. And of course, the collection, even from level 1, has to be done using a digital tool to make sure, data, we increase the chances of accuracy, but more importantly, as Dr. Reem and Dr. Sally both mentioned, reduce the burden on clinicians and make sure they have the data that are available to deliver the care they need to deliver without having to do a lot of administrative work. So that is in digital tool is an important component. Now in level 2, like I said, we're talking about the audit. We're talking about higher levels of achievement in terms of collection and response rate from patients, and also evidence that outcomes measurement has become really routine practice in the organization, such as physicians really looking during a patient consultation and bringing up any PROM result that actually requires attention. So again, they're becoming essentially part of the consultation. And Sally just mentioned it earlier that patient-reported outcomes should be seen as a medical information, medical input, just like clinical input that comes from medical tests or blood pressure measures, etc. because it does have medical value that an attending clinician can act on, either to alleviate a symptom or personalize more the treatment, or adapt a treatment plan and basically address improvement and reduce complications. The other component in level 2 is the need to start embedding outcomes in quality improvement. So the quality function would put more emphasis on outcomes, and actually, while continuing to use process measures, because we always need process measures in our provider sites, but link those to the outcomes they deliver and make changes to them based on the outcomes that they deliver. And of course, in level 3, and this is really an exciting stage here, and I'm sure with the CIV and this national transformation that the kingdom is going through, we are getting to a stage where we are able to start publishing demonstrated improvements in some cases, but also build learning collaboratives that we can start learning more from one another by comparing, at least anonymously, and actually making sure we always deliver the best and most efficient care possible that we can. So this is in a nutshell the ICHOM accreditation with the 3 different maturity level that it entails. And of course, like I said, it does serve as a great guide and a trust across the system. So in terms of some of the challenges faced in implementation, and again, obviously there are many more challenges, but we chose to maybe highlight some of the common challenges, or at least one common challenge on outcomes, which is really response rates. One might think that, if we start, saying PROM is another survey that means to send to patients, and sometimes without even involving clinicians, we end up with, honestly, disappointment at the end of the day. This responses to PROMs require very much a lot of engagement on both the patient and the clinician side. And they need to be already positioned as medical input, as a health assessment, not as a survey, like the, let's say, patient experience survey. They are very different types of essentially input that is collected. And some of the things we've been essentially implementing in the kingdom in particular to actually increase the chances of success really starts with at the beginning, which is the structured patient onboarding and communication. So first, we need to do that physically when the patient shows up and is actually enrolled or registers into the platform for the collection of PROMs, and understand what these are used for. Typically, this is something at this initial stage raised by the attending physician. Again, for patients trust their physicians more than they trust anyone else. So, and obviously there's ongoing what we call A/B testing to know when is the right time to send it, how frequently, etc., to keep on improving the response rate. The second one is the ongoing engagement of the clinician. So the idea that we have a if you like, disciplinary team that meets regularly and looks at the results and try to understand what the results actually mean. And of course, to do that, there needs be some capability building before that will enable this to happen. And then the third component is essentially try to reflect on results to really evolve standards of care or patient pathways. And it's oftentimes those post-acute care or rehab support that sometimes can make a big difference in outcomes, but it's not really addressed adequately or not sufficiently resourced. Of course, we have to also embed this in the flow of patient engagement, and we normally see situations where brochures in multiple languages, the languages that the patients speak, so not just obviously English and Arabic, sometimes we can add other languages, or waiting room nudges and other things that could be done to to make sure really patients understand what this is about and how they should do it. And of course, in some cases, we are seeing the alignment on patient journeys and the multidisciplinary team created is helping us create some sort of integrated practice units, which actually provide also good care navigation for patients. Patients will find it easier to navigate their care, and therefore they will be able to respond better and provide us with meaningful data. I'll go quickly through a couple of cases with real data from our Saudi implementation. The first one, we have multiple hospitals today measuring the ICHOM set on pregnancy and childbirth, which is called maternity sometimes for short. And now, of course, this standard set includes a number of obviously CROMs and baseline data and case mix, but it also has about 10 PROMs that measure mother and baby, pregnancy and post-delivery measures. Now, of course, as you can see, for level 1 accreditation, we have this is limited to 3 main measurements in the middle, in the third trimester, immediately after birth, and 2 weeks post-delivery. And of course, for level 2, there needs to be more measurement. But let me cut to the chase and go through some early observations we are seeing. For example, we do see some the PROMs. Obviously, these PROMs are enabling women, for example, to voice their symptoms, their concerns, which may not be always possible. It may not be possible because of there's not enough always time, not enough consultations. During the consultation time is not enough. Some things can be a little bit embarrassing, maybe. And of course, that's a pity because there are concerns that could be addressed but are not being reported. And so some of the unmet needs that we have seen almost across more than multiple hospitals include urinary incontinence, depression, and satisfaction and sexual function. So clearly they were highlighted, and in some cases, for example, we did not see in the PHQ-2, some hospitals did not really see improvement in, for example, those that scored some level of depression. And of course, that requires also, special attention in order to understand why is this the case and what can we do about it. And indeed, in terms of what we can do about it, again, we have seen, and this is really the nice thing about really being truly patient-centric and really improving people's lives, and in the process, really averting complications and improving efficiency. The thing that excites us the most is we are seeing these pathways become more referral pathways. So if patients are complaining about certain symptoms, that they could be referred to within the hospital, or often rehab centers, or some additional attention that they can that can address their symptoms. And of course, we continue tracking those PROMs to see to make sure that they have actually improved. One final very quick case, also low back pain, obviously a very high recurring condition as well. We've been also implementing it. It has 3 main PROMs and that are essentially that cover the ICHOM pathway. And again, now that this is being measured, we are seeing, for example, very good improvement in terms of disability and pain indexes, really significantly being reduced compared to pre-procedure. And this has really, it is also allowing clinicians to understand what patient to respond to, what kind of treatment that is prescribed. So obviously, this is really another welcomed, improvements that we are seeing. I think the big question once asked is, how can we make this everywhere in the kingdom now that we are seeing that it is happening, right? Finally, a couple of words. So for those of you who don't know us, we are an ICHOM implementation partner, and we're also ICHOM's accreditation partner. And we're, 50% of us is really training, expert and medical consulting, and the other 50% we're a technology company that has VIA, which is Value in Health Agent. It's a data platform, and it also has actually payment and contract administration capability. And of course, we've been very privileged to have had this long history in the kingdom, well, relatively recent, right? Because everything was in Value-Based Healthcare was launched since 2019, and also been working, with the Dr. Reem as well when we worked also on the public sector side in particular. So overall, the key takeaways: standardization is really key. We can start with the iCHOM set and build from there. We need to build trust. Things need to be digitally enabled. You can leverage the iCHOM accreditation for that. Engagement. We cannot emphasize this enough. This isn't a survey. It's a change management with technology, with evidence based to get physicians on board, and with engagement and what's in it for me to get patients on board. Of course, last but not least, it is happening. And I would say want to leave you maybe with one slogan: please join the collaborative. And thank you.
Thank you very much, Dr. Sally and Mr. Faris, for such a wonderful and insightful presentation. I mean, I myself learned a lot from you. Just for the remaining time that we have left, I have a burning question. Just talks about the in terms of the implementation, and this is for you, Dr. Sally, and I wish you get well soon, but I just have to ask you this question. So as a physician, from your perspective and your experience, how does value-based health and care influence the clinical team motivation and satisfaction? Because in order for us to have a successful implementation, we need to have this motivation. So from your perspective as a physician, what do you think?
Thank you very much. Well, I was amazed in Wales, actually, at how universal the support from my clinical colleagues became for value-based healthcare approaches. As long as you can make the data part of it not burdensome, that's the important thing. We can't burden clinical colleagues with this. As long as we get over that, it's such a useful way for clinicians to make it clear how care needs to be influenced, so based on the needs of their patients. So it creates this common language between clinicians and managers in healthcare providers, and policy as well, I would say, so that frontline clinicians are really able to have much more influence again, which I think is very important. But also it's a set of tools to release clinical time as well, which we know is very, very important, and enable clinicians then to be able to spend more time with those patients that need it the most, because of the enablers like the digital enablers and so on. And because you're measuring the outcomes, you know that you're not disadvantaging somebody else. So this has been an incredible journey for Wales, and my clinical colleagues tell me on a regular basis this brings back joy at work for them.
Thank you. Thank you very much. For the remaining time, and we also have closing remarks, I have a question for Dr. Reem, which is from the audience. So now we have those prompt tools, and many of them are developed in Western countries. So there comes the barrier of being culturally appropriate for the context of the country. So the question is, how can we ensure that prompts are culturally valid and are relevant to different populations. And also from then, I invite you, Dr. Reem, to close this session and address your remarks.
Thank you for that question. And, you know, that takes me to like starting by something that Sally, you mentioned on PROMs, is that when you measure PROMs, it doesn't mean you're doing value-based care. It's not the same. And emphasizing the importance of this being a paradigm shift in how we look at what we do in the health sector, because classically we've measured the performance of the sector by activity, by what the doctor thinks, what the hospital thinks, and introducing patient-reported metrics, whether they are PROMs or PREMs or outcome metrics, is a different way of looking at what we're doing in the sector. And of course, when we measure a patient-reported outcome, it needs to be in a language that the patient understands. It needs to be translated in a standardized way, localized and validated. And this is the experience we had in the Paris project that also you mentioned, Sally, in your remarks. Where we went through a rigorous process of translation, and localization and validation in order for us to use this. And to your points, Faris, on standardization. And this is some of the work that we're doing at the center in thinking about standardizing how we do measurement across the whole ecosystem in order for us to be able to compare and understand how much value is being delivered. Now, we also have a huge room for innovation in this area. We heard about this in Sally's remarks. I mean, the new models of care are an innovation in how we deliver care. And introducing this thinking is a way for us to be able to say how well it's working and how well it's working from Eastern versus Jeddah or the North versus Asir, and for us to be able to operate analytically, whether at the clinical setting, I always say that's where the magic happens, or where a hospital administrator or a cluster CEO, or at the national level at large. I'd like to say one more thing before we close on this idea of delivering value. In addition to what we've been speaking about today, which was heavily on measurement, it's also on stewardship, on how we play a leadership role, whether at the front line, middle management, the microsystem, the mesosystem, or the macro level. It's stewardship on how we use our resources from time up to other resources that we measure. And it's on minimizing variation. I mean, we talk about minimizing waste. I mean, sometimes we, the frontliners, feel like we want to do more by ordering more tests or doing more referrals. And these measurements are a way for us to be able to understand how well the care pathway is working. In the words that we heard today about needs, understanding the needs and responding to that. With that, it brings us to the end of our webinar. I would like to thoroughly thank you, Dr. Sally Lewis, international well-known figure in this field, and you're here with us today while you're sick with COVID, and much appreciate that, and much appreciate you, Faris, for being here and sharing the experience from implementations. Really delighted to have you, and for Dr. Khalid for being our host for the day. Thank you very much, and until next time.
Thank you, Dr. Reem, for such informative closing remarks and your warm words. Unfortunately, we're just past time, so I want to thank you, the audience, for the active participation and thoughtful questions. Today's discussion has underscored the importance also in the enablers and the practical steps for the effective PROMS rollout implementation and how it supports the Saudi model of care. We invite you to complete the post-session survey that will be sent to you. Your feedback is invaluable. Stay connected with us on LinkedIn for announcements for the upcoming sessions and our events. On behalf of the Center of Value and Health, I extend my sincere thanks to Dr. Reem Al-Bunyan, Dr. Sally Lewis, Mr. Faris Saadi, and also to every one of you for joining us. We look forward to continuing this essential dialogue. Thank you and see you at the next session, inshallah.